Hello everyone. Today we will discuss pneumothorax and pleural effusion. What is pleural effusion? Definition: excess amount of fluid in pleural space between parietal and visceral pleura. So when there is excess amount of fluid between pleural space between parietal and visceral pleura, so this is pleural effusion. Normally there is up to 25 ml of fluid which is present in the pleural space. When it reaches excess amount, so this is pleural effusion. What is etiology? So there is disruption of normal equilibrium between pleural fluid formation and pleural fluid absorption or exit. What is the classification? Pleural effusions are classified as transudative and exudative and distinguished clinically using Light's criteria. So transudative pleural effusion, what is the pathophysiology behind it? There is increased capillary hydrostatic pressure, the pressure that push fluid outside the blood vessel, so it is increased, and there is decrease in the plasma oncotic pressure, that is the pressure which is maintained by proteins that keep fluid inside the vessel. So the fluid tends to go outside when there is increased hydrostatic pressure in transudative pleural effusion. What is the etiology? There is congestive heart failure, usually right-sided or bilateral, cirrhosis leading to hepatic hydrothorax, nephrotic syndrome, protein losing enteropathy, cirrhosis, pulmonary embolism may cause transudative but more often causes exudative effusion, peritoneal dialysis, hypothyroidism, cardiac failure and urinothorax. Exudative pleural effusions. What is the pathophysiology behind exudative pleural effusion? Is increased permeability of pleural capillaries or lymphatic dysfunction. What is the etiologies? So exudative have infectious, malignant, inflammatory, intra-abdominal, intrathoracic and traumatic etiologies. What are behind infectious? There is parapneumonic effusions associated with bacterial, pneumonic and lung abscesses, empyema, bacterial, fungal, tuberculosis, pleuritic, viral infection, fungal, parasitic, malignancy. The examples are lung carcinoma 35%, lymphoma 10%, metastasis for breast 25%, ovary, kidney, then mesothelioma and myeloma. Behind inflammatory, collagen, vascular diseases, rheumatoid arthritis, SLE, pancreatitis, benign asbestos related effusion, pulmonary embolism, and cardiac injuries, drug reaction. And behind intra-abdominal, subphrenic abscess, pancreatic disease, elevated pleural fluid amylase, Meags syndrome. What is the Meags syndrome? There is ascites and hydrothorax that is associated with ovarian fibroma or other pelvic tumor. So intrathoracic esophageal perforation can lead to elevated pleural fluid amylases, trauma, pneumothorax, rupture of a blood vessel commonly by a trauma or tumors, pneumothorax, spontaneous traumatic tension, chylothorax, iatrogenic, or there may be drug-induced or hypothyroidism. Signs and symptoms. What are the clinical features? Often it is asymptomatic, but there is progressive dyspnea, orthopnea, pleuritic chest pain. On inspection, we can see decreased chest movements on the affected side and trachea deviates away from the effusion. And ipsilateral decreased chest expansion. If we do percussion, we see there is stony dull, but to see stony dull, there should be at least 500 ml fluid is required to make a stony dull percussion to diagnose clinically, and there is pain on the percussion in finger. Decreased tactile fremitus, vocal fremitus is also decreased, auscultation, decreased breath sounds, bronchial breathing and egophony at the above fluid level. There can be pleural friction rub. On investigation, must have more than 200 ml of pleural fluid for visualization on a PA film. In the lateral film, 50 ml leads to blunting of posterior costophrenic angle and it can pick up to 50 ml of excess fluid. On PA view, mild effusion is 200 to 250 ml and there will be blunting of lateral costophrenic angle. In moderate effusions, there is dense opacification of lung fields with concave meniscus and blunting of claustrophrenic angle. In a decubitus view, there is fluid will layer out unless it is loculated and it can detect more than 10 ml of fluid in a decubitus view. In a supine view, we can see fluid will appear as general haziness. CT is helpful in differentiating parenchymal from pleural abnormalities, may identify underlying lung pathology. Ultrasound detects small effusions and can guide thoracocentesis. What is the approach to find the cause of pleural effusion? Before this, we can see some images of the pleural effusion. We see that this is all the effusion covering the lung, and the lung is just white out. This is bilateral pleural effusion. So what is the approach to find the cause? We see clinically by chest X-ray, PA view, lateral decubitus ultrasound and chest X-rays. Look for heart failure. First of all, we will look for heart failure. If it is absent, we will do pleural fluid aspiration. We see if it is transduate, then investigate and treat accordingly. If it is exudate, then send second sample for full cytology, WBC biochemistry. And in biochemistry, we see LDH, ground staining, culture, AFB. And if heart failure is present, then we will do diuresis for 3 days. Then repeat chest X-ray and look for pleural effusion. If again present, then we will do pleural fluid aspiration, or if absent, means we should have to treat the heart failure. In exudate ground staining, if we look here, exudative, from here we continue again. If it is still undiagnosed, then we will do high resolution CT chest. If there can be infiltrates, mass mediastinum, pulmonary embolism, or still undiagnosed, we will do pleural biopsy. Then it will be, maybe it will be TB or mesothelioma or any other malignancy. And if diagnosis is made, we will see biochemistry. If C3, C5 levels are less than SLE or rheumatoid arthritis, then we will treat accordingly. In diagnosing, when we will do pleural tap, always take 3 samples, 10 ml each. Send initially 1 applied to the initial sample. We will send for application for Light's criteria. Then we will inspect for color, character and odor of fluid. Appearance of pleural fluid, if it is bloody, then trauma, malignancy can be there. If it is white, empyema, chylous or chyliform effusion. If it is black, then aspergillosis, amoebic liver abscess. If it is yellowish green, then rheumatoid pleurisy. If it is viscous, then malignant mesothelioma. If ammonia odor, then urinothorax. If food particles, then esophageal rupture. What is the lab values in exudative pleural effusion? All criteria for transduate must be filled to be considered transduative effusion. If any of the criteria for exudate is met, then this is exudative. So we see if there is pleural protein to serum protein, if it is more than 0.5, this is Light's criteria, and in modified Light's criteria, it is more than 0.5 again. The pleural LDH and serum LDH ratio more than 0.6 in Light's criteria, and in modified Light's criteria is more than 0.6. Pleural LDH is more than 2/3 of serum LDH in Light's and more than 0.545 upper limit of serum LDH in modified Light's criteria. If any one of this is met, then this is exudative. So what is the analysis of pleural effusion? If we see protein and LDH, we see purpose for to differentiate between transduative and exudative. If LDH especially high, more than 1000 international units per liter, then this is empyema, rheumatoid or malignancy. Protein is high in TB and myeloma. If we see ground stain, Zeal-Nielsen stain, culture, then look for specific organism. This is the purpose for ground staining, Zeal-Nielsen or culture. If we do cell count differential, the purpose is neutrophil versus lymphocytes, because lymphocyte effusion in TB, cancer, lymphoma and serocytus. If we do cytology, then malignancy or infection. If we do glucose, then low serum glucose in rheumatoid, TB, empyema, malignancy, esophageal rupture, and rheumatoid factor ANA complement in the collagen vascular disease, amylase, pancreatitis, esophageal perforation and malignancy. pH normally about 7.6. If it is low, in empyema, TB, rheumatoid malignancy, esophageal rupture. Blood in mostly traumatic malignancy, pulmonary embolism with infarction and TB, and in triglycerides, chylothorax from thoracic duct leakage, mostly due to trauma, lung C or lymphoma. Cholesterol distinguish between chylous and chyliform effusion seen in inflammation, for example, TB and rheumatoid arthritis. What is the treatment? Thoracocentesis, treat the underlying cause, considered indwelling pleural catheter or pleurodesis in refractory effusions. Now we move to pneumothorax. What is pneumothorax? The word pneumo is for air. So definition is presence of air in the pleural spaces, plural pneumothorax. So if there is excess fluid, that was pleural effusion. If there is presence of air, so in the pleural space, this is pneumothorax. What is the pathophysiology? Entry of air into the pleural space raises the intrapleural pressure, causing partial lung deflation. So what is the etiological classification? There can be spontaneous pneumothorax, traumatic or iatrogenic. In spontaneous, there is no history of trauma. There is two types of spontaneous, primary spontaneous and secondary spontaneous. In primary, there is no underlying lung disease. Spontaneous rupture of apical subpleural blebs, packets of air of lung into the pleural space. There is history of male, smoker. There is family history, Marfan syndrome. In secondary, there is underlying lung disease, for example, rupture of subpleural bleb which migrates along bronchoalveolar sheath to the mediastinum, then into pleural space, necrosis of lung tissue adjacent to pleural surface, pneumonia, abscess, lung, CA, COPD, cardiac failure or TB. What are the clinical features for pneumothorax? Sudden onset dyspnea, pleuritic chest pain, dry cough, tracheal deviation, contralateral deviation in tension pneumothorax, ipsilateral diminished chest expansion, decreased tactile or vocal fragmentus, hyperresonance on percussion, ipsilateral diminished breath sounds. On examination, we see cyanosis in general physical exam, decreased chest movements on the affected side, vocal fragmentus decrease, and there is hyperresonant percussion. What is the progression? If we see pathological classification, if dyspnea starts improving, then it is closed pneumothorax. If the shortness of breath or dyspnea is static, then this is open pneumothorax. If dyspnea is worsening, so means it is acting as one-way valve and opening as one-way valve. So it is tension pneumothorax. So we investigations, we see chest x-ray, we will do PA view, increased translucency of the affected side, we will see jet black lungs because of loss of pulmonary vasculature. So we can see jet black lungs in tension pneumothorax, trachea is deviated away the contralateral side, and this is again jet black lungs. So what is radiological classification? Small, there is in small there is separation of viscera and parietal pleura seen as fine precenteric line parallel to chest wall at apex. Less than 15% of lung volume is affected. In moderate, 15 to 50% of lung volume is affected. In massive, decreased density and decreased volume of lung on the side of pneumothorax, so more than 50% of lung volume is affected. In treatment, if there is primary spontaneous pneumothorax, it means that it is small, stable, less than 3 cm, less than 15% of volume is affected, minimal symptoms. So we will do observation and oxygen. We will do observation and will give oxygen. Then discharge and follow up, and we will do chest x-ray after 7 days. If it is symptomatic or large, means it is more than 3 cm and more than 15% of lung volume is used. So we will do aspiration with second intercostal space. If it is successful, then follow up chest x-ray after 7 days. If it is unsuccessful, then repeat aspiration. Again successful, then follow up chest x-ray after 7 days. If unsuccessful, After repeat aspiration, then we will do chest tube intubation. If chest tube intubation is successful, then again follow up after 7 days with chest x-ray. If unsuccessful, means there is persistent air leak more than 72 hours, so we will do pleurodesis or VATS. What is pleurodesis? In pleurodesis, a sclerosing agent like talc or bleomycin is injected in the pleural space through the chest tube, which causes obliteration of the pleural space. In secondary spontaneous pneumothorax, we will see if it is stable, small, less than 3 cm with minimal symptoms, then observation and we will give oxygen. If symptomatic, large or unstable, then chest tube intubation. If successful, then observe. If unsuccessful, then VATS. So in unstable tension pneumothorax, needle decompression, then chest tube, and VATS if unsuccessful. In recurrent pneumothorax, again pleurodesis and VATS. Now we will see MCQs, so we will have better idea for pneumothorax and pleural effusion. Case number 1, we see a 20-year-old white man was stabbed in the chest in a bar fight and arrived at the emergency room within 30 minutes. So he was stabbed in the chest. You notice that the trachea is deviated away from the side of the chest that suffered the puncture. If you suspect pneumothorax, which of the following would you expect to find on the traumatized side? So we have already discussed that there will be, in pneumothorax, there is hyperresonant percussion. So a pneumothorax refers to a collection of gas in the pleural space resulting in collapse of the lung on the affected side. So a tension pneumothorax is a life-threatening condition caused by air within the pleural space that is under pressure, displacing the mediastinal structures and compromising the cardiopulmonary function. A traumatic pneumothorax results from blunt or penetrating injury that disrupts the bariatrial or visceral pleura. So the physical findings classically consist of absent tactile fragmentus, hyperresonance to percussion, and decreased breath sounds on the side with the pneumothorax. So here hyperresonant percussion. Case 2, a 21-year-old white male is brought to the emergency department by his friend after he was stabbed on the right side of the chest at a nightclub. He presents with chest pain and shortness of breath. His vitals are BP 85/45, mmHg heart rate 125 per minute, respirations 31 per minute, and temperature is 37.7 degree. A portable chest radiograph revealed tracheal deviation to the left. So he was stabbed at the right side and tracheal deviation to the opposite. Which one of the following would you expect to see on the physical exam of this patient? So we will see hyperresonant. He will be hyperresonant to percussion because this is again tension pneumothorax. It is characterized by trachea moving contralaterally to the site of the chest injury. Physical examination revealed decreased or absent breath sound, decreased tactile fragmentus, and hyperresonance to percussion. Then case number 3, a 47-year-old male presents with a complaint of fever and a recent 3 kg decrease in the weight loss. On examination, his temperature is 38.6 degree and his BP is 110/65 and pulse is 80 per minute, respirations 22 per minute. His pulmonary examination revealed decreased breath sounds and dullness to percussion and decreased tactile fragmentus all on the right side. So this is fragmentus. His trachea is deviated to the left. Which of the following is most likely led to your diagnosis, led to your answer? So what is this? This is pleural effusion because pleural effusion is characterized by decreased breath sounds and decreased fragmentus, dullness to percussion over the side with effusion and deviation of the trachea to the opposite side. So this is pleural effusion. Case number 4, a 69-year-old male presents to the emergency department with complaints of suddenly increased shortness of breath. He was diagnosed with COPD 10 years ago. His medications are tiotropium, formoterol, and albuterol. Usually, when he is short of breath, he uses albuterol, which alleviates the symptoms. However, now this time it not helped much. This time he has smoked 40 packs of cigarette a year for the last 45 years. On physical exam, he has hyperresonance to percussion and decreased breath sounds on auscultation at the right side. His oxygen saturation is 87%. So what is the next appropriate step? So he is also having COPD and smoker. So this is most likely pneumothorax and also hyperresonant to percussion. So what is the next step? So we will do oxygen administration at 3 liter per minute by nasal cannula. Because sudden increase of shortness of breath, unilateral breath, decreased breath sounds on auscultation and hyperresonance to percussion in a patient with COPD history suggestive of spontaneous pneumothorax. So oxygen supplementation through a nasal cannula is an appropriate initial treatment for spontaneous pneumothorax. Now case number 5. You are called to the bedside of a 72-year-old female on mechanical ventilation for 3 days who suddenly develops chest pain. Her face is contorted in pain and she points to her chest. She has 40 pack per year history of smoking and long-standing COPD. Vital sign shows a blood pressure of 85 by 55 mmHg, heart rate of 120 beats per minute, respiratory rate of 24 breaths per minute, and oxygen saturation of 80%. Physical exam reveals absent breath sounds over the left side of the chest and normal S1 and S2 heart sounds without any murmurs. What is the best next step in this patient? So, what is the best next step will be insert a large bore needle into the second left intercostal space, because this is again the question for pneumothorax. So in this patient, you see that sudden onset of chest pain, which is suddenly develops chest pain, and decreased or absent breath sounds on one side suggest tension pneumothorax. So in the tension pneumothorax, the first step in treatment is insertion of a large gauge needle into the second intercostal space of the affected side, and this is very crucial in the treatment, and tension pneumothorax should be diagnosed as soon as possible, and the lung should be treated with insertion of a large bore needle into the second left intercostal space in this case, so that the patient life threatening situation can be handled. Case number 6. A 35-year-old male consults you about a vague chest pain he developed while sitting at his desk earlier in the day. The pain is right-sided and was sharp for a brief time while it began, but it rapidly subsided. There was no hemoptysis and the pain does not seem to be pleuritic. There was no hemoptysis and the pain does not seem to be pleuritic. His physical exam EKG and oxygen saturation are unremarkable. A chest film shows that 10% right pneumothorax. Which of the following is true regarding this situation? So he should be treated with outpatient observation with a repeat chest radiograph in 24 hours, because in this patient, the majority of the patients presenting with spontaneous pneumothorax are tall, thin individuals under 40 years of age. Most do not have clinically apparent lung disease, and the chest pain is sometimes minimal at onset and may resolve within 24 hours. So because in this he developed the pain while sitting at his desk earlier in the day, then it rapidly subsided. So patients with small pneumothorax involving less than 15% of hemithorax may have a normal physical examination although tachycardia is occasionally noted. The diagnosis is confirmed by chest radiograph. Studies of recurrence have found that an average of 30% of patients will have a recurrence within 6 months to 2 years. The treatment of an initial pneumothorax of less than 20% may be monitored if a patient has few symptoms. Follow-up should include a chest radiograph to assess stability at 24 to 48 hour. Indication for treatment include progression, delayed expansion, or the development of symptoms. So here we will do observation with a repeat chest radiograph in 24 hours. Case number 7, a 25-year-old male comes to the emergency department with the sudden onset of moderate to severe right-sided chest pain and mild dyspnea. Vital signs are normal. A chest will show loss of markings along the right lung margins involving about 10 to 15% of the lung space. The mediastinum has not shifted. The best initial treatment would be, again, because this is again pneumothorax in which less than 10 to 15% of space is involved. So there will be oxygen supplementation and close observation. Then a 60-year-old male with a right-sided pleural effusion undergoes thoracosynthesis. Analysis of the pleural fluid reveals a protein level of 2.0 gram per dl and an LDH level of 70 units per liter. His serum protein is 7.0 gram per dl and the serum LDH is 200 joules per liter. Based on these findings, so this is 200 units per liter. Based on these findings, which of the following is most likely diagnosis? So this is heart failure. So the pleural effusions may be exudates or transudates. The distinction is important for an accurate diagnosis and to help determine what further evaluations may be necessary. Light criteria use rates of fluid to serum values for protein and LDH. So pleural fluid and serum ratios greater than 0.6 for LDH and 0.5 for protein are indicative for exudates, as we have done in that table. In the scenario presenting, both ratios are approximately 0.3, therefore the fluid is a transuate. So the list of causes of transuate is much shorter than for exudates. The vast majority of transuate are due to heart failure, with cirrhosis being the next most common cause. Once there is reasonably certainty that the fluid is transuate, additional studies usually are not necessary. The other conditions listed in resulted in exudative pleural effusion. So congestive heart failure accounts for 90% of the transudative effusions, usually small bilateral effusions, but unilateral effusions do occur. 12% are more common on the right side by a ratio of 2:1. So hope you have got some idea about pleural effusion and pneumothorax. Thank you.